Bismillahirrahmanirrahim. Welcome to this session on multiple sclerosis. First speaker, Professor Dr. Thomas Berger, University of Vienna. He will speak about new strategies with disease-modifying therapies. Please.
So thank you very much for this introduction, and I'm also very honored and especially grateful of being invited again to participate in the CNC conference and to be in Cairo to meet all my good old friends over decades and to meet new colleagues. So it's very nice to be here again. I was asked to talk about new strategies with disease-modifying therapies in MS, and in brackets according to the mechanisms of injury. And for that purpose, apart from my disclosures, I have to state, for that purpose I would like to refer you to a, I think, very important paper by Tanja Kuhlmann and colleagues about 1.5 years ago, where she summarized all the mechanisms of injury in multiple sclerosis and thought about how could we measure those in real life, in the routine practice, but also to enhance or to foster research activities around these mechanisms of injury, which are much more than just counting relapses because of the inflammatory activity. Now, if we think about new strategies in DMT use or future developments, then I think we can start on several angles by using this framework of the mechanisms of injury. First of all, it is a matter of fact, if we change diagnostic criteria, we automatically increase the efficacy of treatment. Which means, specifically, if we go to old data, and these are already some years ago, and especially covering a cohort for many decades, you can see that by changing the time point of diagnosis has an influence on the start of the disease-modifying therapies and obviously also on the future disability. Which means in essence or in a nutshell, the earlier we diagnose, the earlier the patient receives treatment and the more likely it will be prevented that they have substantial reach of EDSS milestones. Now, this is of course very important because, as I said, the earlier we diagnose, the more patients we will also include which probably have not a very severe disease course, and therefore automatically all the use of disease-modifying therapies will be better than in the decades before regarding their efficacy. And this specifically also regards a very hot topic nowadays, and this is the question of the radiologically isolated syndrome. You heard during this conference yesterday at the workshops, but I guess also during the conference itself, a lot about the radiologically isolated syndrome and the definition whether this is preclinical MS, asymptomatic prelude of MS. But as a matter of fact, it was now included in the proposed revisions of the McDonald criteria. So this is a very new scenario because it tells us we're having now included a condition which is clinically asymptomatic and biologically defined by an MRI finding. I don't want to talk about the radiologically isolated syndrome in detail, but I would like to highlight that whatever the diagnostic criteria are incorporating, one major point is still and permanently incorporated that MS is still an exclusion diagnosis, which means that everything which has no better explanation turns out then to be MS. However, we all are aware that in the meanwhile there are two clinical trials published with regard to treatment of radiologically isolated syndrome. On the one hand, dimethyl fumarate, on the other hand, teriflunomide. And what you can see here is that obviously the treatment in this very early preclinical stage seems to be effective in turn of outbreak of clinical definite multiple sclerosis. However, the summary with the current summary about the radiologically isolated syndrome, I think, is manifold on various levels. The first thing is incidental MRI findings will increase because around every corner we have now MRI machines in our radiologically offices, so the incidental finding will definitely increase more or less incrementally. Which means, on the other hand, that we are more confronted as neurologists with, let's say, findings by chance, and we have to deal with that. Which means that we need to urge ourselves to a high attention regarding the differential diagnosis and not to brandmark our patients at a given time point with multiple sclerosis, where we can't really be sure that all of those patients harbor a risk factor. Because, as we all know, it's about 30 to 50%, 5 to 10 years risk at the stage of the radiologically isolated syndrome to develop multiple sclerosis, which means, on the other hand, 50 to 70% will not develop MS within this time frame. And importantly, there is a very strong trigger factor which drives this risk, and this is the spinal cord lesion. I think this is a bit intuitively, because recall among your own experience how many patients, asymptomatic patients, are receiving a spinal cord MRI. I don't know whether they are really clinically asymptomatic, but nevertheless, we have two clinical trials, and so far the guidelines, on the one hand, will include the radiologically isolated syndrome as part of the MS diagnostic family. But on the other hand, there is no clear recommendation upon treatment. I think this is something which should be decided on the discretion between you and your patient. What is definitely mandatory is, and this is also a shared decision, is to follow up and to monitor the patient if appropriate and also wished by the patient. Now, another thing we can think about if we have new strategy concepts about disease-modifying therapies is to improve our tools. And the tools means either tools for stratification to certain disease-modifying therapies or also tools to monitor the efficacy of the treatment. Now, this is not that trivial. I think in a landscape with nearly 20 approved treatments, but on the other hand, as let's say the majority of our patients will be treated or are treated, I think we need to consider that new clinical assessments are obviously of utmost importance because, and I would like to refer you to a quite tantalus work we did some 2 years ago, asking in a systematic literature review how or which are the best clinical assessment tools and how good are they in defining treatment outcomes in a clinical daily practice. And for that purpose, we searched more than 9,000 articles circling around outcome of clinical trials, And we separated and stratified those studies into clinical outcomes, paraclinical outcomes, which is mainly MRI and OCT, and patient-related outcomes as well, because we all know that this is getting more and more mandatory also to assess the individual patient's view on the efficacy of a certain treatment. And then, of course, any combinations. Now, what you can see here are two graphs regarding the clinical and the paraclinical outcomes. And to read those graphs, it's very easy. Everything on the right upper corner is very good, which means the cycle and the upper right corner placement indicate that this is the current best assessment. Now, having said that, look at the results. It's on the one hand counting relapses and on the other hand assessing EDSS. And in the paraclinical framework, it's the neuron enlarging T2 lesions and the GAD enhancing lesions. So to be honest, not really surprising and also not very innovative, because that's what we are doing the past 30 years. Now, one of the messages is that on the one hand, it is quite reliable, and I think it's still valid also for clinical trial outcomes, but also in clinical practice, because it is a language everybody understands. So with all the limitations those assessments have, everybody around the globe, neurologists, but also patients, understand this language of assessment. Nevertheless, we need to think about the more and more better the fate and the journey of the patient gets with regard to disease course, we need to think about what about new tools and which are better than just counting relapses on the one hand and transferring our neurological examination in an EDSS score. And so far, I think our, let's say, future hopes are quite disappointing because we don't have really good tools at the given time point for clinical routine practice use. There are some, let's say, on the edge of being probably used. I think especially OCT is a highly promising tool, very easy, non-invasive, quite low cost, and also used for individual monitoring. As soon as this is established, I think as a routine practice and also a routine monitoring, I think that would be a very supportive measure, especially with regard to disease progression in individual patients. Biomarkers have always been a hope. Neurofilament lights and GFAP are circling around our efforts for nearly 15 years or longer. So far, I think it's not really established for routine use, and the search is going on. Nevertheless, we need to be honest to ourselves that the majority of our patients, especially if they are entering the progressive disease course, and everybody is advertising that this is already a matter from very early disease course on, it is highly difficult to assess whether somebody is truly benefiting from a treatment, because the majority of our patients will deteriorate over time. Probably only in a very subtle way, 0.5 EDSS scores, something like that, which is not very obvious and not individually harmful. But we need to regard whether this is a treatment effect in terms of treatment response, or if this is a treatment non-response. Now, coming to another point, of course, new treatments. This is the intuitively self-explaining first reflex. If we need to define the mode of activity, the mechanism of pathology in MS, then of course we also need to identify new targets and new treatments. I'd like to refer to one of the reviews. This was among ours. And I think one of the most promising disease-modifying therapy groups are the BTK inhibitors. And the reason for that is that they have, on the one hand, two major modes of action. The one is B cell activation, blockade, and inhibition. And on the other hand, they target microglia cells, which are moving more and more in the focus of interest with regard of the so-called smoldering inflammation within the brain. By the way, of course, there was a huge developmental program, and I just cite Emmanuelle Lepage with a very good talk at ECTRIMS 2 years ago, where she summarized all the clinical trials. And unfortunately and very disappointingly, there was in December 23 the information that the evolution clinical trial, which is evobrutinib, one of the BTK inhibitors, completely negative. And I have to confess, I've never seen such a negative study as this evobrutinib. So there was the question, of course, is it a matter of study designs or is it a matter of non-effectiveness of BTK in real world? However, the good news followed, and last year, exactly at ECTRIMS 2024, there was the presentation of the tolebrutinib trial, the Hercules trial, and the Hercules trial was a trial in non-relapsing secondary progressive MS cases, and it showed here approximately 30% risk reduction as compared to the placebo-treated patient. So, obviously, the clinical trial was statistically significant. However, whether this is also clinically meaningful, we will see in short time, but at least the program continues, and it gives us a little bit of hope that this group of BTK inhibitors will work in patients with a progressive disease phase. What about other new treatments in the pipeline? To make a long story short, it's not that promising and not that innovative as we had in the past 20 years. This is just a list of potential new drugs. I'm a bit skeptical, to be honest, that they will have a really breakthrough result. However, one of the breakthrough results could be by a complete new concept, which is, of course, not invented for neurology and neurological autoimmune disorders, but for hematological disorders, and these are the CAR T-cell therapies. There are approvals for CAR T-cells in especially B-cell malignancies, but there is also a growing interest to use CAR T-cell therapy in autoimmune disorders, including also neuroimmunological disorders. And the rationale for this CD19 CAR T-cell therapy is to have a kind of deep tissue depletion, because you don't use any monoclonal antibodies anymore, which have to pass the blood-brain barrier. You use T cells, and the T cells cross the blood-brain barrier, of course, in a good way. And the first clinical trial results came from a case series from patients with lupus, patients with inflammatory myositis and systemic sclerosis. And again, to make a story quite short, there were treatment refractory patients, and none of them had any relapse anymore. So it obviously, at least in this published case series, plus many other individual cases, myasthenia, multiple sclerosis, it turned out that this is a quite promising treatment concept, which of course needs a lot of further investigation, also conceptually, because the interesting thing is, and nobody knows whether this is friend or foe, is that these CAR T cells are detected in autoimmune disorders only in a median of 40 days after application. And this is quite different to the hematological condition, where they are detectable up to 120 days. But it might be that this is a advantage for autoimmune disorders. Nevertheless, we also are confronted with extremely rare but very specific side effects in this concept of CAR T cells, which means mainly driven by the virus vector, which may induce secondary malignancies. And there are some publications from last year, case reports, which are definitely the consequence of the CAR T cell therapy and not secondary to the fundamental malignancy. So I'm coming to my end, and based on these mechanisms of injury, I think we need to develop new strategies of our disease-modifying therapies rather than just awaiting the next treatment group with a specific mode of action. We have to adjust our activities in terms of classification, but also assessment. And the assessment, I think, will be of crucial importance also with regard to future benefits of any new treatment or intervention we are applying to our patients. And with that, thank you very much for your attention.
Thank you, Dr. Thomas. We postpone the question to the end of the session. Oh, you are leaving now. Any question to be answered? Yes.
Thank you very much, Professor Thomas, for this very interesting presentation. My question is about the future of the BTKIs. After the failure of the first one, I think that a major part of this failure was because of the pharmacokinetics and dynamics of the component itself. Because even in pharmacokinetics and dynamics of the other BTKIs, they are better in many things. So this is one part of the question. The other one is, do you think that in the future, the BTKIs could be with other anti-inflammatory medication? Because it seems that they are working on the smoldering lesions and the progression more than they are working on the active inflammation. So could there be combination therapy, let's say, in the future?
Yeah, very good questions. I have to confess that I don't know really the answer because not the full data and all the details are so far published or available. But nevertheless, I agree that it will be quite difficult in this very specific population of non-relapsing SPMS to define for which population the approval should fit for. With regard to combination therapy, of course, intuitively, we would think, yes, anti-inflammatory plus a BTK. Intuitively, yes, but I'm afraid that our health authorities will get a heart attack if we start with combination therapies. And I'm also not quite sure whether the given time point is already ready because it has not been studied as a combination therapy. So therefore, I'm not quite sure if we can really draw any scientific evidence for a combination therapy so far.
No other questions? Okay, now we shift to the next speakers. It's my pleasure to introduce ثنائي الفني عندنا الدكتور مجدي وماجد. هيكلموا عن الريميتنج او relapsing multiple sclerosis landscape and unmet needs and a new therapeutic approach.